Well, hello and welcome to today's webinar. We're coming to you from Alliance Magazine in London, and we're joined by friends and colleagues all around the world. I'm Charles Keedon, Executive Editor at Alliance and the moderator of today's webinar. Alliance has just published a new issue dedicated to global health philanthropy. Today, I'm delighted to be joined by the guest editors of the new issue, Julia Greenberg and Aggrey Aluso of the Open Society Foundations, as well as Stephen Allen from the Validity Foundation, who's contributed to the issue as well. At $46 billion each year, philanthropy spends more on health-related issues than anything else. It's 1/4 of all grant making, and philanthropy has provided critical funding for vaccines, medical equipment, social welfare, and global health infrastructure as the COVID-19 pandemic unfolded. But there's also intense debate about how the largest foundations interact with governments, international bodies, and pharmaceutical companies, and who should hold them accountable. So our new issue explores whether health funding is going where it's most needed and asks who gets to decide. The centerpiece of the new issue is an interview with the Director General of the World Health Organization, Dr. Tedros, and other contributors include Ban Ki-moon writing about philanthropy's role in delivering universal health coverage, the Wellcome Trust on their role in the search for a COVID vaccine, drawing on lessons from Ebola, as well as the Children's Investment Fund Foundation on the new funding agenda for sexual and reproductive health and rights. And I hope that has whetted your appetite for what you're going to hear today. But before I hand over to our guests, I'd encourage you to check out the offers button on the right-hand side of your screen. Alliance is offering all of you on this webinar a free print copy of our Global Health Philanthropy issue with any donation over £5 to Alliance Magazine. As a registered charity, Alliance generates much of our income, but we also rely on your support to keep bringing you trusted, independent, and expert insights from across the global philanthropy sector. So simply click on the offers tab on the right-hand side of your screen, and you can both donate and receive your free print issue. And also, while you're looking at that right-hand side of your screen, please take a moment just to familiarize yourself with the chat function. Tell us where you're from, and feel free to submit any questions, and I'll do my best to put them to our guests as we go along. So now to the main event. Our first two panelists are guest editors of the new issue. Julia Greenberg, who is Director of Governance and Financing at the Open Society Foundation's Public Health Program, and Aggrey Aluso, who manages the Health and Rights Program at the Open Society Initiative for Eastern Africa. In their article, Julia and Aggrey make the case for a more citizen-centered approach and question the over-reliance on private sector solutions by some foundations. So turning to you, Julia, warm welcome to you. Thanks for all your work on the issue that you guest edited. What were you hoping to offer to the sector, and how did that help shape your coverage?
Thanks, Charles, and good morning, afternoon, everyone. I'm delighted to be with all of you today as this insane year winds down. And I'm just reflecting that when Charles contacted Aggrey and I to consider guest editing an issue of Alliance on Global Philanthropy during the height of a pandemic, when the public health program at OSF was exploding in every direction, figuring out how best to respond, when my kid had finally finished school from home while I worked from home and I was struggling to figure out what on earth to do with her all summer, I thought, you must be completely insane. But after I collected myself, I realized I couldn't pass up this opportunity. I was aware somewhere in the back of my mind that the pandemic was laying bare all of the possibilities of global health philanthropy, but also all of the perils and problems. And the opportunity to guest edit this with my colleague Aggrey, whose political analysis of the health sector guides me every day, would provide me with some time to grapple with what I was learning and feeling as a public health professional in the context of philanthropy during a pandemic. So that was how this opportunity came to us. And before I launch into how we wanted to shape the edition of Alliance, I wanted to just say a couple of things. In our guest editing role, we were primarily looking at global health funding flowing from rich countries to middle and lower income countries. So that is just some context for my comments. And also, as many of you probably know, Open Society Foundations understands public health as an entry point to social and economic justice issues. So this edition of Alliance was shaped very much with that perspective in mind. So with that said, this is what we hope to bring forward in the edition of Alliance. First, a reckoning with the fact that philanthropic actors and entities working in global public health are part of a geopolitical and economic power structure, whether we like it or not. We need to make funding choices with a clear-eyed understanding of the context. And did we ever see this playing out during the pandemic, where political decisions trumped, yes, evidence-based ones again and again, leading to painful numbers of deaths from COVID? Please have a look at the centerpiece interview with Dr. Tedros in this issue for his moving words about how he had to negotiate the politicization of health as he was leading WHO through this unprecedented pandemic. Two, we wanted to shine a spotlight on the fact that the scale of global health philanthropy is huge. As Charles said, $46 billion in 2017 and 2018. The sheer amount of our dollars and the unfortunate narrative that we and our management consultants know best plays a role in eroding faith in the notion that the state can and should take care of the health of their own citizens. And this has massive unfortunate consequences. And related to the above point, we need to examine whether our funding is contributing to the fragmentation and privatization of health systems around the world. And if it is, we need to stop funding the way we're funding. In the case of philanthropic and public funding coming out of the US, where I live, from USAID, PEPFAR, and others, we need to question whether we are exporting failed healthcare models, like, frankly, the one that we have in the US, to middle and low-income countries through conditions tied to our funding. And we discussed this a little bit in the lead article in a piece around maternal child health funding in Uganda, which I recommend you have a look at. One example from the lead article that I think brings together many of the reflections I just shared concerns the vaccine, and that's of course something that's on all of our minds these days. And like all of you, my heart jumped for joy when I started to see the pictures of UK citizens getting their jabs on Tuesday. And as a Yankee, I just love saying jab, so I'm going to say it a few more times probably during this webinar. But as a funder of economic justice and health, I couldn't help but also think about the latest stats that many of you would have seen yesterday from the People's Vaccine Alliance, which, yes, OSF does help to fund. Only 1 out of 10 people in 70 middle and low-income countries will get their jabs or shots by the end of next year, while the rich world can vaccinate their people in some countries as much as 5 times over. And the 5 times over bit is Canada, if you are interested. Our article highlights the role of the Gates Foundation, brokering deals with 15 pharmaceutical companies to expand global access to COVID therapeutics, diagnostics, and vaccines. And of course, that sounds good. Access to medicine is exactly what's needed in the context of a global pandemic and faltering healthcare systems. But let's be real, vaccines were overwhelmingly developed with public money from the US, from European countries. And the article, we argue that these kind of philanthropic private sector partnerships run roughshod over deeper efforts to change the intellectual property rules and monopoly pricing that enable pharmaceutical companies to massively profit off of the pandemic by selling vaccines that were developed with taxpayer money. We argue that it should not be for private foundations, including any of us, and pharmaceutical companies to set the terms for access to vaccines for low-income countries in a pandemic. This is the role of national governments, held accountable by civil society and member state-driven multilateral institutions. And I could go on about the many inspiring ways leaders in developing countries are trying to change the mechanisms that enable affordable access to vaccines, like invoking rules at the World Trade Organization, like calling for the transfer of technology and knowledge on vaccine access. But unfortunately, leadership of rich countries, and in some cases backed by foundations, are blocking those moves. So that's the context and our understanding of where our work fits. And it's a specific context. There are many different ways you could frame it. And in doing so, we wanted to be real about where we were, but really think affirmatively and with some inspiration about where we could move as a philanthropic sector when it comes to global health. So quickly, here are some ideas that we hope will provoke discussion throughout the webinar, but also in our work moving forward. First, mind the gaps, but don't fill them. Global health philanthropy has been magnificent in taking up controversial issues that are difficult for national governments or donor governments to fund because they're stigmatized and politicized. These include mental health, which Steve will talk about in a minute, access to sexual reproductive health and rights and abortion services, access to health for socially excluded and criminalized groups like migrants, trans, lesbian, gay, and intersex people, and sex workers. We need to keep doing that. But we shouldn't think that this is our role in perpetuity. We have to also support citizens that can push governments to take care of these communities as well. And in terms of the edition, which I hope you will all get your free copy of, we recommend the article by Suzanne Petroni and Linda Weissert on self-care and gender equity. It's a beautiful example of creative funding in this regard, which I've been really inspired by. 2, support the system changers. I'm inspired not only by the NGOs and movements calling for people's vaccine, but also by the national advocacy taking place around the globe for publicly funded, sustainable, coherent healthcare systems. This includes the fight for Medicare for all in the US, the fight against the slow erosion of the NHS in the UK, and importantly, the fight for universal health coverage in Kenya. I highly recommend Angela Nguku's excellent article in the edition about philanthropy's role rolling out UHC. And it's interesting also to compare it with the Ban Ki-moon article as I think about it. 2 different takes on the same subject with lots of commonalities. Next, and this we've just been hammering away at forever, and I don't know how to fix it, but we have to support the local organizations and actors to reform their health systems as they see fit and resist supporting the massive international organizations that work supposedly on behalf of beneficiaries, I'm saying in quotes, in low-income countries. I just don't think philanthropy should be funding the multi-million-dollar contracting organizations that work for donor governments and are extracting wealth from low and middle income countries rather than supporting sustainable development. And finally, if this pandemic and the inspiring racial justice uprisings that happened during it has taught us anything, it is that racism and economic inequalities are public health crises that need to be addressed cross-sectorally. From my perspective, we do not need yet another commission on the social or political determinants of health. We know what they are at this point. What we need is to actively seek partnerships with economic and racial justice funders and movements. And this is not, again, saying, hi, we're a health funder, Mr. Economic Justice Funder, please take on health. It's about understanding and willing to take on their priority issues like criminal justice reform or debt relief, for instance, as matters of public health. So with that, I have shared the top line reflections in the fascinating work on this edition. Charles, thanks so much for giving Aggrey and I the opportunity to play a role in shaping this, and I'll hand back over to you.
Thank you, Julia, for that very clear exposition of some of the critiques you have of global health funding as it's currently undertaken, but also some views about different directions. And just want to go back to you with one question. Sounds from what you're saying there's a bit of a tug of war, if you like, between those foundations that are more inclined to, if you like, engage with civil society and to really think about kind of the impact on local populations, and those that are working maybe more at an elite level with contracting organizations, governments, and pharmaceutical companies. And do you think there's room for both? Foundations like Gates would argue, I presume, that there's increasing amount of engagement on their part with civil society, as well as their work with pharma. So do you see it as a healthy tension, or do you actually think there needs to be a sharp kind of break and change of direction in current practice? Julia, in case you can't hear me, make sure that your mic is on.
Yes, it wasn't. Thanks, and that's a tough question. I see it as a tension. I'm not sure that I see it as a healthy tension because of the sheer scale of the funding coming from private sector and private foundations into public systems. It would be one thing if there was some sense of balance. And it's interesting that you raised this, Charles, because the 2 critiques that I got of the article, which I really take on board, one came from a colleague, Salima, from ICER in Uganda, an organization that we feature in the article, saying, do you really think philanthropy shouldn't be giving funding to governments? And the answer is no, I don't think that we should never be doing that. In fact, there's a great and rich history of donor governments and organizations providing budget support for countries to enable them to find some funding for core support of how they want to move their health systems and other development issues. But I just don't think, given the current context, the distortion of the levels of funding coming from private actors and philanthropy and the deep influence they have over multilateral institutions and national government in their health decision making, that we can say it's a healthy tension. It's a tension, and it's one we have to work through. And certainly OSF and the Gates Foundation find plenty of common ground and opportunities to work together on key issues where they take on and support civil society and fund human rights policies in the multilateral organizations. But if you zoom out, I think the data that the issue brings forward really shows the distortion that I think we have to grapple with as a sector.
Thank you, Julia. And just before we go to Aggrey, we want to just get views of people listening here to this kind of tension or division of where philanthropic funding should be directed. So if you go to the first poll, you'll see the poll icon on the right hand of your screen. We wanted just to ask you a question. In your experience, do you think health funders need to work more with A, civil society, B, pharmaceutical companies, C, governments, or D, international bodies like the WHO, or E, all of the above? Or let us know in the chat. So just if you want to just submit your initial kind of reactions to this, I'll just give you a kind of few seconds just to do that. Great, and we'll pause it there. And there's a majority of 51% really emphasising focus on civil society, but also some who argue that governments and international bodies are important to engage with too. We'll probably just follow up and reflect on that, and of course any of the other panelists are free to comment on it too. Thank you for your input on that question. And now I'm delighted to turn to Aggrey Aluso in Kenya. Aggrey is a manager for the Health and Rights Programme at the Open Society Initiative for Eastern Africa, which is a sister body to the Open Society Foundations. And Aggrey brought his own political analysis, as Julia was saying, and perspective on these issues, which was immensely valued to the kind of global view that we were trying to build up. So delighted to welcome you, Aggrey, and hand the floor over to you.
Thank you, Charles, and good evening, good morning, everyone. I'm delighted to be part of this sharing. Just like my colleague Julia, I was also, this came at a time when my colleague Julia alerted me on this opportunity to co-author the Alliance publication. I was in the thick of things. It was in the middle of the pandemic, as it still is, and it has been. I was leading the response in the East Africa, and it was quite some tough call. But I think we were persuaded by the necessity to share our reflections. I think we've gathered all over the years. We are also very persuaded because of the issues that are coming to the limelight during this COVID period. I think it's very, very stark clear to us that we are facing some unique challenges that are historical in nature, and which a lot of them had to do with the subject matter of the publication in terms of how the philanthropy has been structured over the years, and whether that has helped or not helped develop health systems to be able to, respond and be resilient to situations like what we are facing now with the COVID. So for us, we saw this as an opportunity. Personally, I saw this as an opportunity to reflect together, all the collectivity of feedback we've gotten from our community that we work with, the hopes, the needs, the frustrations across the world, and particularly in the Sub-Saharan Africa and Eastern Africa where I operate. The reality of the fragility of the health system is something that has come out very clearly now. Most African countries are barely able to manage the COVID pandemic, and we're just, counting our luck that it has not been as devastating as it has been elsewhere. Otherwise, we don't know how this would have been. But we still don't know the trajectory of how the pandemic is going to shape up in the coming future. So it's still a very much critical issue for us, and we are happy to reflect. And I think we also clear that, and if you look at the article, African countries are largely donor dependent, particularly in the health sector. And if you read the lead article, you'd see that governmental and philanthropic donors provide over 40% of all health spending in 9 African countries. That's like literally running the health sector in those particular countries. And therefore, I think that informed our questions of our lead question, is philanthropy too much and not enough? And we couldn't help, personally reflecting with my co-author Julia, couldn't help reflecting whether philanthropy is playing role or the role of a puppet, a puppet string for continued colonial model control of the global South through the health financing. Because as you see in the article, nearly a quarter of the global giving goes to health, and I don't know whether that's by chance or that's something that is deliberate for a sector so critical and which really would make us claim our sovereignty. And the fact that, as I mentioned, 9 African countries depend on more than 40% of their health funding creates, particularly precarious and unhealthy dependency and power asymmetry that confer opportunity to the givers, who are then able to exert undue influence on health policies, and in other sectors, so to speak. And for us, we're always aware that there's nothing like free lunch. And these, donations or these philanthropic gestures come with strings attached. And we highlight in the article that data shows preeminence of private foundations and donor governments, coming in with their own geopolitical interests or niche, through the funding that they give. And this, I often seen or reflected in health policy making in the lower income countries. And I think the fact that despite the colossal giving to the health sector, philanthropy has not caused meaningful transformation in the health system capacity in the sub-Saharan African countries. That's a fact that is also very, very clearly laid bare at this particular moment in time. We have countries like Uganda. At the beginning of the pandemic, there were only 57 ICU beds against a population that is about 35 million. A country like Kenya had about 300 ICU beds for a population that is nearly 50 million. So if things got to the level where it was in Europe and the US, the capacity to offer critical care is basically non-existent, and we're already seeing that happening. This is not surprise because we've seen the type of the philanthropy, preferred models of financing, which, as Julia mentioned, target disease-specific models as opposed to health system strengthening models, which therefore leaves these fragile, health systems. So the one thing that is stark clear and which we bring out in the article is that health philanthropy depoliticizes health in Africa and compromises political accountability. And we say it's like an analgesic rather than catalytic, investment that would help build capacity. It has, been framed, health has been framed as a charitable issue that people accept whatever they get and don't expect much from the government because it's this widespread notion that is covered by the donors, and therefore domestic governments, go scot-free. It's a black box, as we say in the article. So therefore, we make a case for thoughtful giving, as we call it. Our point departure from the lead article is that philanthropy is not entirely bad, but rather there's need for thoughtfulness at this time. I think the pandemic provides an opportunity to reflect on the complicated political and economic role that we play, in this space. We gave an example of a citizen-centered approach, which Julia talked about in Uganda, where modest funding from 3 foundations, Hewlett, Wellspring, and Open Society, supported a local organization, to really take on to the government and demand for accountability, leading to a Supreme Court ruling affirming that actually maternal health is a constitutional right. And over that period of time that the case was going through the paces of justice, the Ministry of Health had to overhaul its reporting mechanism, and we've seen a drastic or tremendous improvement in the maternal health outcomes in some of the areas where these cases were being, provided a base for this case. And these affirms, in conclusion, these affirms our position that strategic support, building the local community leadership to seek local solutions instead of filling the gaps, offer the best prospect for sustainable transformation that would guarantee right to health in Africa and other countries that receive, aid for health. Thank you very much.
Thank you very much, Aggrey, and thanks for the perspective you brought to this issue of alliance. Just want to just bring in a question to you from the chats, rather than asking one of my own. Francis Lovemore says, governments need to learn to budget to provide adequate healthcare for citizens. The responsibility has been shared because the donor picks up the heavy tabs. So, in a way, what it seems to be suggesting in this comment and also in what you're saying is that philanthropy, in a way, has been doing harm and has avoided the changes and the structures that are needed. Could you just briefly comment on that and what you think would need to change in philanthropy for that situation to change?
Thank you very much, and I think the comment is spot on. So philanthropy is not bad, but philanthropy needs to be strategic in terms of building the capacity of the government to, of the government, the citizens particularly to be able to hold their states, who actually has a contractual agreement with them to delivering certain, expectations, particularly in the health and social sector broadly. So if you have aid that is structured to fill in the gaps and, play the role that the government is playing without interrogating, where the monies that are collected through taxes go to, and just continuing uncritical support to this state, it perpetuates this dependency, and it disempowers the citizenry, who therefore do not see, they don't have the opportunity to interrogate the donor on why you're not asking the state. Yet the donor has also created a dependency that has disempowered them from asking their state, their national government, the hard questions of why you're not offering this particular service to us. So these are historical issues that started from the colonial era, where health was traditionally delivered through charitable, avenues like the churches. In Africa, most health services are delivered through very charitable framing, and we have accepted that. And philanthropy has come and reinforced that charitable attitude towards health. And I think that's what needs to change, so that we empower people, towards recognize this as an entitlement, as a right that has a political cost of not delivering on. Thank you.
Thank you, Aggrey. Sorry about that. I was having a couple of technical problems with my own, but thank you for your response. And on that point about the kind of colonial aspects of health funding, there's a very interesting graphic in the issue from Global Health 50/50 that points to the very northern-dominated basis of the personnel that populate and lead the public health infrastructure around the world. So it does raise the question about whether changes in the way that where those people are trained and where they serve might also be part of that decolonization agenda which you speak. But I'd like to shift focus now onto Stephen Allen, our third guest. Stephen's a lawyer and advocate at the Validity Foundation. And in Stephen's article for Alliance, he's talking here about kind of mental health issues and the field of mental health funding. He says we do not only need to pump funding into mental health and by extension into psychiatric hospitals all over developing countries. What we need are investments grounded in human rights. So a very interesting angle on questions around mental health funding. And it's a pleasure to welcome you, Stephen. Over to you.
Thank you so much, Charles, and thank you for giving me the opportunity to provide a few remarks today. and also for inviting me to submit an article for this special edition, edited by Julia and Aggrey. I think it's a really fantastic set of articles, and it really helps push the debate forward, particularly after some of the comments Aggrey mentioned about the need really to move beyond this sort of charitable model of investing in health. And so I'm going to be giving a slightly different perspective because I work for a human rights NGO, and we're actually based not in Western Europe. We're based in Budapest, which is Central Europe, but we work across Eastern Europe and also in Eastern and Southern Africa. And I think my first comments will be about engaging in this field, in my view, requires us to look well beyond the health paradigm per se and look at some of the structural and institutional deficiencies which together restrict or deny access to the right to health. Stigma, discrimination, poor implementation of policies and inadequate participation of beneficiaries of funding are some of the key barriers that donors and investors must, I think, be sensitive to when targeting their investments. Now, of course, this applies across the field of health investments. That includes potentially mental health investments, but I think there's some issues that we need to look at more carefully here. So, Charles, Julia, Aggrey, when you reached out initially to me to contribute to this magazine, you asked whether I could draft an article about the need to invest in global mental health. I think in response you received my slightly garbled text message typed on my mobile phone in the middle of the Hungarian countryside, just at the time when the pandemic was really upticking here in Hungary. I think I said in response I'd be happy to draft an article, but I probably would not be stressing the need to increase investment in mental health per se. Instead, I would argue, as my organisation does, that a better way to improve the psychological and social well-being in our societies was for donors to move beyond this public health discourse towards a more discourse grounded in human rights. Indeed, I think an early draft of this article that I wrote was entitled "Don't Invest in Mental Health. Human rights are the thing that's important." And I very much appreciate all of your humility in allowing me to make this argument. So in the really short time I've got for these comments, I want to explain the reticence that you can hear from me on this question. A form of reticence which is indeed shared with many human rights advocates, disability rights advocates, and of course persons with psychosocial disabilities, particularly across developing countries. I use the term specifically psychosocial disability on purpose in this dialogue. Usually in this field, the language adopted is derogatory. It uses terminology such as mental illness, mental health, treatment, and mental disorders. My central argument is that investments in this field must instead be guided by a philosophy of human rights, and that really does push us well beyond the public health paradigm. Why is a very reasonable question to ask. You could ask me, isn't there a right to mental health too? Well, of course, I'm a human rights lawyer, and I would absolutely agree there is a right to mental health. But investing in this right alone cannot be an adequate response to dealing with the structural and institutional barriers which exclude, isolate, segregate, and degrade the position of people with psychosocial disabilities across so many of our societies. Indeed, the discourse of psychosocial disability is about reclaiming participation, reclaiming citizenship, reclaiming human rights. So my purpose here is not to undermine the impetus for change. It is to argue that a limited focus on investing in healthcare infrastructure has the potential to do harm to movements of persons with disabilities, and particularly those movements that are led by people with psychosocial disabilities. There's a few important reasons for this. First, there's a risk that investing in mental health in a discrete manner, as opposed to investing, for example, in the inclusion of persons with psychosocial disabilities, will in fact result in replicating coercive and other human rights violative forms of psychiatry. Here, I'm talking about the risks involved in building new psychiatric hospitals, for example. Western psychiatry has long defended practices such as involuntary detention, involuntary treatment, seclusion, and restraints as valid forms of treatment, locking people away from the rest of their societies. Ever since the adoption of the United Nations Convention on the Rights of Persons with Disabilities, we can no longer defend these practices. These practices clearly breach core human rights standards, and they cause incredible harm. Secondly, and I think Julia and Aggrey have both already alluded to this point, there's a real risk that increased interest and investment in the field of mental health will actually strengthen the power that some global corporates have, who are interested simply in opening new markets, particularly for psychopharmaceuticals. This medicalized approach again reduces people with psychosocial disabilities to objects of charity, to come back to Aggrey's point, and does nothing to challenge the disabling barriers which so often negatively impinge on their mental well-being. And I will add on this point, this is not a pure risk. We already see evidence of investments coming from the major pharmaceutical firms in parts of sub-Saharan, Eastern and Southern Africa, which are really pushing and in fact influencing the course of mental health legislative reform, for example. So I think that this is a really big and real current threat. And thirdly, we're already seeing, in my view, that this debate around mental health is becoming dominated by the voices of professionals and practitioners. We hear frequently from public health experts, from experts in global mental health, from those who are experts in public policy and systems development. The list goes on and on and on. We also hear, of course, from family members. But it is concerning to us, and this is important to my organisation, that the real experts, persons with psychosocial disabilities themselves, are rarely heard. There is a long tradition of this in many of our societies in the global north as well as the global south, of people speaking for people with mental illness, speaking on behalf of those who are disordered, deciding for those people, instead of respecting their autonomy and respecting their own ability to choose. This is a fundamentally outdated and flawed charity-based approach, which in my view ignores, worse still rejects, the fundamental dignity that all persons with disabilities have the right to have respected. So to conclude, in my view, we need to shift this debate on from the charity-based flavour which it currently has in the domain of mental health. That flavour, which I think Aggrey already pointed out, can be really very problematic. Investments in this area, as much as any other area of social justice, must be empowering. They must advocate for full respect of human rights. And it is important that reforms include and are led by those who are supposed to benefit. That is, persons with psychosocial disabilities. And so, to conclude these remarks, I'll just finish where I started. Let's not invest in mental health. Let's instead invest in human rights and genuine inclusion for all persons, including persons with psychosocial disabilities. Charles, thank you.
Thank you very much, Stephen, for another very clear and well-articulated set of comments. I think there's sometimes an assumption in the philanthropy world that when mental health is discussed, it's typically been a neglected issue, and therefore any discussion of increased funding is just a good thing in general. But I think, as your points make clear, that really is just the start of the discussion and not the end of it. And where and how that funding is directed is a very important consideration. And just to see whether everyone listening agrees, I want to just move to a poll to get your view, people listening's view. So if you go to second poll, I'll ask really a question about this new focus of funding for mental health. Do you think the focus of new funding for mental health should go to expansion of traditional psychiatric interventions, such as access to drug therapies? B, inclusion of people with psychosocial disabilities, C, overcoming stigma and discrimination, D, improving housing, and E, developing personal assistance schemes, or all of the above, and feel free to comment in the chat. It'd be great to just get briefly just your views on those questions. Thank you. Okay, well, thank you very much for your responses. It seems to be as almost half of you are responding to say that overcoming stigma and discrimination is the most important area, followed by inclusion of people with psychosocial disabilities. So, Stephen, if you just want to just very briefly comment on that reaction from the people that are listening here, and then we'll move to some more questions.
Yeah, thanks, Charles. Well, I think as a human rights advocacy organisation representative, I'm heartened by that answer. I think we are only at this point, at very early stages of understanding how the financing is flowing in this field. It's only in the last couple of years, really, that mental health has become a global investment priority. And I think, as you sort of said before opening the poll, this hasn't really been on the radar before, and the discussion about the risks and the challenges really hasn't even been started as yet. And so I saw a comment here from Miroslava Tatarin saying that it's about overcoming stigma, discrimination, but that we also need to look at a wide variety of community-based supports, including access to justice. And I think we would really strongly support that view. For us, purely dealing with this issue as a health rights issue really does run the risk of medicalizing people with psychosocial disabilities. And in fact, there has been a big movement over the last 20 years prior to the adoption of the CRPD. We've got to move beyond this kind of psychiatric, medicalized notion of mental health and recognize that there is diversity among our societies, and that there are many other factors which cause trauma, distress, and social ruptures that need addressing here. And we shouldn't put all of our faith, I think, in a medical approach to achieve greater inclusion.
Thank you, Stephen. And if I could just bring in Julia here, what's your thoughts sitting in a role in an important foundation in the US and globally about these debates on the direction of mental health funding? And what are you seeing from some of your peers across the philanthropic world in relation to this question?
Yeah, I mean, I don't think I have more expertise than Steve or Aggrey on this, but I mean, I certainly, as a financing person, as somebody who looks at health governance and financing, you are absolutely seeing the ascendance of mental health as a global health priority, and the risks, the perceptions of which I share with Stephen is that even the language about it looks at global burden of disease, what the economic impacts are of such a heavy burden of disease, and that is not the frame that we want to start with. So when you see, as a global health financing watcher, when you start to see the World Bank and the WHO organize high-level meetings, ministerial meetings on this issue, I think that's exactly the moment where this community-centered, right-centered discourse has to be really strengthened, and that advocacy groups need to be supported at all levels, from the local to the national to the global, to intervene, because this is really the problem, right? The discourse and the agenda setting happens in Geneva or Washington, D.C., and is absent from what's actually happening on the ground. So from a financing and governance perspective, that's the trend that I see.
Thank you. And just to bring in some other questions, there's lots of people introducing themselves in the chat, and some of you asking questions, and thanks for that, and do keep them coming. Raymond Ampil, he asks, how have your institutions engaged with the geopolitical issues and analysis in these countries and regions to inform your grant making and advocacy work? What in terms of the sister organization of the OSF, which is headquartered in the US, how are you bridging that gap between what's happening in the US and where you are?
Thank you, Charles. And that's definitely a very tough question. My colleague Julia may step in. But I think it's it's an enduring challenge that we are all very aware of. And I think we are cognizant for us who work enough for the philanthropic organization, but within this very predominantly aid-receiving region, with a lot of policies being set outside this region that affect the architect of health financing. I think what we have done as a foundation is to bank on our global network. So, for instance, Julia is very well connected, within the global network of philanthropies and systems of health financing. And what we do is to identify the challenges of policies, those top-down policies that put restrictions or that impact on health, delivery of health, or the architect how health financing a model in this region, and then we fashion out advocacy agenda that then our colleagues who have a global mandate are able to intervene and help engage with our peers at that level. With varied levels of success, it's something that we are always cognizant that we can do much about, but we continue to learn and explore how best we can be able to be more impactful, so that there's more congruency between the global policies that guide philanthropy and the reality on the ground. But Julia, I think you really can also chime in here, given your experience in this area.
Please do, Julia.
Great, and I'm horrified that people seem to have lost the audio while Aggrey was making his really good comments, but I think people are mostly back. I mean, I just give an example of working. Yes, it's the unique and privilege of working with Open Society Foundations, and that we are a global network that works across human rights and social justice issues that allows us to do the political analysis of all of our work. But if you just look at our work in Kenya on universal health coverage, we couldn't have done it would have been impossible to do the kind of funding that we did without understanding why the Kenyan government was pushing so hard on the universal health coverage agenda. So we learned all of the national political issues from Aggrey, from grantees, about how President Kenyatta really sees this as a legacy issue, how he is going to put forward a vision of UHC that is not necessarily consistent with the realities of rolling out the programs on the ground, and that because of his national political aspirations, we needed to make sure that we were funding groups to actually push for transparency on what's happening on the ground and make sure that that the government is held accountable for the rollout of UHC, and it's not just seen as a done and dusted success story. So there's always a political reason for why a certain health policy is being pushed, not always, but usually, and that's the kind of work that we are able to do in order to inform our work. I'll stop there.
Thank you, Julia. That's very clear. And just another question that was directed at you earlier. I would just want to bring in a question from Sylvia Brown, who says, what advice would you give to the millions of individual donors who want to support health in emerging markets but are not foundations or billionaire donors? What sort of charities should they support? And what sort of charities do you support in this area when you take off your kind of institutional hat? Julia.
I love that question, and I love taking off my institutional hat, so thanks. I mean, look, I really think it depends on personal preference, right? Like, there are people who just feel incredibly inspired by groups like Doctors Without Borders or Médecins Sans Frontières doing incredibly important health relief work. Those are the really visible organizations working at both national and community level that have more access to funding. There are fantastic organizations that combine health, rights, and empowerment, like, I feel like I can't plug grantees, but I would think about groups that address health rights needs that aren't necessarily health organizations, like the Network of Urgent Action Funds, like the African Women's Development Foundation, groups that tend to be raise their money from foundations but are closer to the realities of the ground. So that's a couple of ideas.
Thank you, Julia, and thank you for taking that institutional hat off. You did that frequently during the editing of this issue, and we're really grateful for that, and it definitely shows in what we're able to do together with the issue. Have another question that's from Anne Campbell. It was directed at you, but with your permission, I'd like to just ask Stephen Allen, actually, given his work. How can we reframe the burden of disease terminology and narrative to something more effective? Over to you, Stephen, if I may.
Hi there. So thanks very much. And I'll declare that Anne is actually my colleague. So that's funny that the question came to me, but it's a discussion we have a lot in this field. And I think the reason we have this question is because mental health financing has become dominated by, as we say, this kind of medicalized approach. But I do think it's really important. One of the things that was mentioned earlier is to raise the voices of the final beneficiaries of this financing. And we really need to give a primary position to the final beneficiaries of this financing. And we don't see anything like that at present. And I think one of the earlier questions was about, okay, are you working in the field to try and understand the dynamics and how you're targeting your investments? And whilst we have seen a lot of evidence of that, I think, in respect of universal healthcare, responding to the HIV and AIDS pandemic, or epidemic, I should say, I don't think we're yet seeing that in respect of mental health. And one of the issues around that is that requires engaging directly with organizations of persons with psychosocial disabilities. Now, unlike other broad health rights campaigns, organizations of people with psychosocial disabilities are invariably tiny. They're invariably unable to access general funding sources, sometimes even from some of the foundations here, because they're not going to meet registration requirements in their countries. They're not going to be included in broader networks and disability rights and health rights movements. And so it really requires an even more kind of careful assessment. And Validity certainly works with small networks like that across Eastern and Southern Africa, for example, and we regularly try and discuss with donors and others how to provide the support, the platforms that are necessary to get those voices out there. But I think we are far, far from that right now, and there really needs to be a really strong kind of commitment to doing this. Otherwise, we are going to be, as I mentioned before, replicating that biomedical approach, which actually does not improve dignity.
Thank you, Stephen. Do either you, Julia, or Aggrey want to also respond to that question?
I could not give a better answer, so I'll pass.
I'll pass too. I think that's adequately addressed.
Oh, okay. In which case, I'll go in a moment just to some other questions that have come in. But I just wanted to say sorry to any of you that had some audio difficulties. I hope they've been resolved, but if not, try reconnecting and hopefully you'll be able to hear the proceedings. So just want to go to a couple of questions that were submitted in advance. Giles Sion from an organization called Future Earth has said that the world is in desperate need of a clear vision for health-related research, together with stakeholders from different sectors. And his question is, how are the panelists thinking of integrating science into their funding priorities? Who would like to respond first to that?
I'm happy to. First of all, I would say that there's, of course, a huge amount of funding going into health-related research. I forgot, Charles, if you want to dig up the statistics on that from Candid. But clearly, the evidence base for public health is crucial at all and at all moments in order to make sure that our interventions are actually addressing the core causes of the spread of disease. And while we look at OSF from a human rights perspective, we absolutely rely on high quality research. So from our perspective, again, because of the way in which we fund, I would say a couple of things. First, there's a movement toward implementation science and community-based research, which is a missing piece of the puzzle when it comes to the research agenda in global public health. We really need to know how scientific interventions, public health interventions play out at local levels, or all the research in the world won't make change. So that's one piece of work that OSF doesn't do enough of, but when often we are pushed by our grantees to do so, we should. Secondly, I would just like to reflect from a governance perspective on what's going on with the global health architecture and who is in charge of really guiding the global health research agenda, right? What gets funded gets looked at. And the lack of democratic governance across the global health sector, I think, is something that we really need to look at. And from my perspective, we really need to beef up the democratic governance of the World Health Organization and their ability to carry out real-time research when it comes to not only pandemic preparedness, but also UHC and other key disease issues that we're talking about, rather than funding a proliferation of privately funded research actors that are not feeding into some kind of unified whole.
Thank you, Julia. And I'm just looking at the time and realizing that it's flying by and we've only got a few minutes or a couple of minutes left. I just wanted to give the floor to Aggrey and to Stephen just for any final reflections or comments they have, either based on what they're hearing today or what they're seeing you're seeing in the chats. Perhaps we can go to you first, Aggrey.
Sure, thank you. And actually, I just wanted to say something slight about the research question, which I think is very, very important. That research and development is one of the biggest gaps that we see in most African countries, which has given an entry point for philanthropic organizations, of course, with the vested interests that we talked about, to really start the influencing of the landscape of what is prioritized and what is not. There's very little that is done by the domestic countries, the national states in Africa region. Like in Kenya, for instance, there's a study just concluded recently I was looking at, which shows that the government, for example, supports only about 0.01% of the researches that are done. So the bulk of it comes from outside. And of course, those who dictate the research agenda, dictate what gets prioritized. That's the way of influencing prioritization. So it's one of these very, very strategic areas that I think organizations, philanthropic organizations in the strategic catalytic thinking that we're talking about should be able to direct attention to such gaps. So that we can have more indigenous informed, research agendas that therefore would influence, priorities that need to be addressed from, genuine understanding of the needs of the locals. And just generally to thank everyone. I think it's been a very exciting experience. I've learned a lot from the articles that were put together by other colleagues and just being part of this process. And the questions that have come through, I think, are very illuminating. Thank you, everyone.
Thank you, Aggrey. And over to you, Stephen, just for a final word.
Well, thank you again for bringing in my slightly critical voice in this debate. I really appreciate the opportunity, and so do my colleagues. I will link my final comment to the research one, which is that people with mental health issues, quote unquote, have regularly and often been objects of research, but they're rarely seen as subjects of human rights. And if we want to really support a catalyzing development agenda to improve dignity and human rights, then we need to be seeing people with psychosocial disabilities as the researchers, coming up with the solutions, that donors should then be investing to improve inclusion at the community level. We're starting this research in Uganda. We are doing some of this research in Zambia. I think we're already seeing some really interesting ideas emerge about how to link traditional and non-conventional forms of service with conventional services. And I think we need much more of this type of research, led, designed, analysed by the people who are the final recipients of this assistance. And thank you very much to you all for the really stimulating discussion today.
Thank you, Stephen, and we always appreciate critical perspectives here at Alliance. So it's great to have yours in this issue and on the webinar today. In the spirit of cooperation and further discussion on global health, you'll see in your chat some other webinars that are taking place. One by funders concerned about AIDS, Human Rights Funders Network, Global Philanthropy Project, and Africa Grantmakers Affinity Group on the 15th of December. And also Chatham House have one about COVID-19 and solidarity, which was also posted there. So do follow the discussions that they're having, as well as the ones that we're having in Alliance. So I do hope you've enjoyed today's discussion. Don't forget to go to that offers section if you haven't already and get a free print copy of our new issue, which will give you access to the opinion, debate and insight on global health funding, as well as news and views from around the world of philanthropy. Just any donation of £5 or more to get that. Thank you in advance to those. Thank you for those of you that have done so already, and please do so if you haven't. And I'd just like to end just by thanking our expert panelists, in particular our guest editors, Julia Greenberg and Aggrey Aluso from the Open Society Foundations, and, as I was saying, Stephen Allen from the Validity Foundation, to all of you for the new and different perspectives you're bringing to the discussion on global health philanthropy. And I'd also like to thank the Alliance team that are behind the scenes working very hard to make what we do possible, and in particular our marketing, advertising and events manager, Amy McGoldrick, who's produced today's event. And thanks to all of you who have been part of the Alliance community and continue to be as we go into our 25th year next year. Our webinar series continues in January, when we'll be taking a look at the growth of philanthropy partnerships across the Global South with our colleagues at Cambridge University. But for now, thank you for engaging on the subject of global health philanthropy, and best wishes for 2021. All the best. Bye-bye.